Hi, everyone, and welcome to MedEdge. I'm Marcus Scrim. Quick reminder, MedEdge is brought to you by Medtrics. Medtrics is the premier engagement platform for students, residents, faculty, and administration for both UME and GME. Learn more at metricslab.com or from my co-host. He's in the house today, Medtrics CEO Santosh Charan. How are we doing today, Tosh?
I'm doing great.
I hope you're ready, buddy. This is going to be a fun one. You know, it used to be medical education had two very large components, preclinical and clinical. Do them right, you get to be a doctor. But along the way, let's face it, healthcare became complex. Today, if a patient complains about a healthcare issue, more than often than not, they're not unhappy with what the doctor said or did. Rather, they're complaining about maybe how it was coded wrong or how one provider missed talking to another. And yes, if in fact the treatment was covered by insurance. Well, this other bucket of stuff has a term, and that term is called health system sciences. It's a comprehensive framework that encompasses the principles and methods needed to understand and improve how healthcare is delivered. According to the AMA, about half of all medical schools have deeply integrated HSS into their curriculum. Well, today's episode of MedEdge is for the other half of you. Tosh, you're younger than me, so we often have generational conversations, but I don't think you're that much younger than me. When you went through medical school, was HSS part of the curriculum?
When I read this paper that you did, it was really fascinating because I didn't have that. You know, my exposure to a lot of the health system science or EHR and how to do discharge summaries, it only happened when I entered my clinical rotations and I'm being taught in a internal medicine rotation or family medicine rotation. So having that exposure earlier would have been helpful. And this also made me think about something that led me to radiology as a specialty. When I went through my second rotation in my fourth year, I never understood what a radiologist actually felt like practicing radiology because I never sat in front of a computer and looked at a CT scan or a PACS system. So I remember one time a radiology resident said, why don't you sit here and instead of sitting behind me and falling asleep and scroll and see if you can find the pancreas. So that actual act of sitting there and scrolling and looking at the pancreas, and it was a very different experience than sitting behind someone and learning about whatever they're looking at. So that made me realize it's like solving puzzles. So if you give some of this exposure earlier, if I had that exposure as a second year or third year resident, maybe I would have had that insight earlier. And it applies across the board. Some of that clinical things, I didn't have that. I think it's really wonderful that you're doing that.
But you know, it's crazy, Tosh, and this brings us to today's guest because, you know, here's what I do know. Okay, so you weren't exposed to HSS, but I also know med school wasn't easy for you. Your caseload was huge. There's a lot to do. So the problem with that definition of HSS that I just shared is how are we supposed to shoehorn anything comprehensive into that intense curriculum that's necessary to become a doctor? And in this world that we live in, how will we ever improve healthcare if we don't? So, Tosh, we've got a great guest today, Dr. Vineet Arora. She's one of the co-authors of a paper published by Academic Medicine, which is the journal of the Association of American Medical Colleges. This paper is titled Development and Implementation of an Experiential Longitudinal Health System Science Thread into an Existing Medical School Curriculum. So it's how do you take that HSS and how do you get that content into all the other things that tomorrow's physicians need to learn? I'm going to tell you how that study ended. In the study that preceded the paper, more than 100 M4s were asked about their competence in areas including effective communication at discharge, knowledge on safety event reporting, and considering costs and making healthcare decisions. Those are all the things, Tosh, nobody taught you. But guess what? The results were through the charts. It turns out when we make an effort to teach some of new ideas to some of the brightest minds in America, guess what? They are more than up to the task, which brings us to today's guest. Dr. Vineet Arora is a Herbert T. Abelson Professor of Medicine and Dean for Medical Education at the University of Chicago Medicine, Pritzker School of Medicine. As Dean, she oversees undergraduate medical education and GME and continuing medical education. I love this full story here, and provides key leadership for the simulation-based training programs at the University of Chicago. As an advocate for improving equity and opportunity in academic medicine, she has been an influential voice for women in medicine and leads NIH-funded programs to improve mentoring for women and minority future physician scientists. I've learned your friends call you Vinny. Vinny, you are here among friends. Welcome to MedEdge.
Thank you so much for having me.
Our audience is made up of UME and GME. So we've learned we can't get into the podcast without talking about origin stories, because everybody's like, oh, well, where'd she go to school? How'd she decide to become a doctor? Undergrad at Johns Hopkins, medical school at Washington University in St. Louis, residency at the University of Chicago, where you finally put down some roots. You've been there more than 2 decades. Is that where you're from, or how did it become home?
No, I'm definitely not from Chicago. I'm an East Coaster, born and bred. My parents and family are still back there. And actually, I will catch myself because, every, around the winter holidays and summer break, those are my times that I can, quote, visit home. And people are like, where is your home? And I was like, where I grew up, So, so I grew up in Maryland, stayed close for college, and then made it to the Midwest for medical school and really fell in love with Chicago as a big city. But part of that also was, I'd been at these really amazing academic institutions, but, so much of your life is sort of integrating your loves and your passions. And so when I was at Hopkins, I used to tutor biochemistry and econ in the undergraduate library, but then I would take 2 shuttles to do research down at what's now Bayview, and I remember the shuttle ride. It was like, okay, this is I was getting up at 6 in the morning, 5 in the morning, go on a shuttle. And I was like, okay, I don't want to be on a shuttle. And then when I went to WashU, I was in medical school, so on the medical campus, and then I would take a shuttle the other way back to the undergrad to teach MCAT, because I taught MCAT prep for, Princeton Review and Kaplan both equally. And so when I came to U Chicago to interview for residency, it was just really unique and, attractive to me that the hospital was here on the main campus, and you could literally walk outside and be in the med school or be in the undergrad quad or be in the law school, business school, or public policy school. And that was always an interest of mine, is studying medicine and something else. So actually after residency, I did a master's in public policy here. So I'm an alum of the University of Chicago too, but not in medicine. And the secret is I married a Pritzker alum. And so you live in a city when your kids root for their sports teams. So I raised Chicago sports fans. And then I was like, okay, I guess I live here now. So
that is awesome, and yeah, Chicago is a great city. I applaud where you landed. Here's a line I'm going to steal from an article that was written about you by the Jewish Healthcare Foundation. Dr. Arora is an academic hospitalist and medical educator who specializes in improving the learning environment for medical trainees and the quality, safety, and experience of care delivered to hospitalized results. And I think that sums up well a lot of things we're going to be talking about today. And what I love about the work that you've done is a lot of the papers that you published are not what I would think about as traditional clinical care. You're working around these really important pieces that hold together health sciences. You've studied the impact of sleep on residents and patients. You've covered income equality among women doctors. So much of medical education is about those clinical fundamentals. But you're one of those people that you're just really attracted to the health system sciences. Why is that?
Well, I think this goes back to, my training at U Chicago in public policy. And it was right around 2000 and, 2. So really 2001, 2002, it was really interesting time in healthcare. So 2 things had happened. One is the Accreditation Council of Graduate Medical Education, which oversees residency programs in the United States, had announced that they were going to implement resident duty hours, so cut work hours for the first time. I mean, it was really like you could work, there was some language here and there, but it wasn't codified across residency. So even though 80 hours is still quite a long time to work, the fact that we were going to an 80-hour work week and capping at 30 hours, a marathon shift meant something. And so that was one thing. And so it was sort of like, well, we have so much, like when you rotate on cardiology, everyone's like, what's the evidence for this, drug that you're about to give? But for medical education, we're just like, oh yeah, it's like it was been like this forever. Let's just do it this way. And similar for a lot of stuff in the health system, like vital signs every 4 hours. There's no evidence for that. It dates back to Florence Nightingale, and so I have always been interested in answering those questions that don't, like, why do we do it this way? Because it's always been done this way. What's actually the evidence? And so that's what kind of drew me to those questions. The other thing that happened around that time period was that CMS, Medicare, Center for Medicare and Medicaid Services, announced that they were going to measure hospital quality for the first time. So you saw two different organizations, one in medical education and one in healthcare, really put their nickel down to say, we're going to be in the patient safety and quality game. And I had just finished my residency, and no one had talked to me either about patient safety or quality in my, like, they were just not even existent. So when I found out about the Medicare changes, I was like, no one knows about this. No one, I would go around being like, have you heard about this to the doctors I work with in clinic? They're like, no, So that's really what motivated me to go in this direction.
It's really interesting to me. And we've had a lot of, I think one of the things that there's many things unique about the work that you've done, but it's really interesting to me that you've been in Chicago for 20 years, right? Because you've been able to see how things were 20 years ago, and then you've been part of this seismic shift. And I actually kind of want to ask you about, Chicago's ability to really get serious about HSS. When the AMA initiated Accelerating Change in Medical Education Consortium in 2013, it included 11 schools. University of Chicago hopped aboard when it expanded to 20 schools in 2015. So I kind of want to ask you about that period. Clearly, it's obvious from your work and everything that we have read about Chicago. You folks are always early, but you weren't in that original cohort. And I'm just curious if you can think back, getting serious about some of these issues that have just never been addressed before: patient safety, cost management. It took you guys a couple of years. Was it due to other priorities, or did you just say, wait, this is going to be a massive undertaking? We need to build stakeholder alignment. Just talk to me about how, I would say University of Chicago wasn't on the bleeding edge, but they were on the leading edge. Just talk to me about those first couple of years.
So interestingly, I had really been doing a lot of my work in GME at that time. And so we were really on the leading edge on the GME side. So we were one of the first cohorts of pursuing excellence for clinical learning environments, team training in the residency environment with nurses to improve quality and safety. So a lot of it is like where you have leverage. And being an associate, I started as a chief resident, associate program director, then worked in GME, and kind of worked my way up the hospital ladder. And so when this opportunity came for undergraduate medical education, we had put something forward in that early, bid, but it was more of a, who's doing something in this area that we can work with. And I was part of it, and we wrote in for it. We didn't get chosen. In full disclosure, sometimes you don't get chosen in that first round. But it gave us that GME experience, gave us the impetus to apply the second time. And what's interesting is the second time, I remember somebody's like, "Are you going to apply?" And I was like, "Oh, I don't know. They didn't want me, and it was less money too. And our dean and our, one of my mentors at the time, my former person in this role, Holly Humphrey, who now heads the Macy Foundation, said, well, is there a way to just take the things that you are passionate about that you would want to do anyway and sort of, be aligned? And so I do think we had greater alignment and greater experience because if it was a GME issue, I feel like we would have been very strong. We needed to get a little bit more understanding of how we could change the undergraduate medical education program this way,
Oh, there's so much great to come out of that. I mean, it's leveraging your strengths, leaning into what you're really good at. But it's so funny. We interview so many great guests here. And it's so easy I think listeners to get the perception of, well, these people are winners in everything they do. So I love you sharing the fact that you didn't get in the first time around, which is pretty amazing, given your bio and given the reputation.
What I really love about the work you're doing is you're tackling it both from the academic perspective and research, but also being in a leadership role, you're also making this practical. And how do you roll this out? Is some of the things that you mentioned about, the every 4 hours you're doing vitals. I see a lot of times in medicine, we pass down information to students and residents, and that's how it works. The apprentice training model, because you pass it down and they repeat it to somebody else. When you are trying to implement change like this, what are some of the ways that you get people that are, residents and students, they will, if you say this is the new way you do it, they get agreement and you move on. But for attendings and faculty members, how do you get them to do things that are different and not what they were trained to do?
Yeah, absolutely. So I should also say, we're all creatures of habit, including students and residents. And so education, and I should say, don't quote me, but I'm going to be on a podcast saying this, but I've said it before, which is we cannot change behavior with education alone. So talking at a lecture, very low level intervention, the system and the way the system works is actually way more powerful teacher than anything a professor will tell you. So you could learn something like, you should wear your white coat every day. And if you go into the clinical setting and everyone's wearing scrubs and, or their fleeces, you're not going to bring your white coat, right? So it's the power is in what people are doing in the settings that they're doing them in. And so for us, we really think about a framework. We've developed a framework with two of my colleagues who've studied high value care for many years. We wrote a book on this called Understanding High Value Care. And it's called the COST framework: culture, oversight, systems, and training. The training is the very last piece, okay? Because if you haven't fixed the culture to be receptive to this new training, the training's not going to stick. The oversight, bad habits are going to come back. So who's going to be able to give you that feedback, because that's how we learn to grow. And then systems, I often say to, especially to residents, and practicing physicians and nurses, worked with a lot of interprofessionals. We are never going to come and tell you to work harder. We know you work hard, right? We want you to work smarter. So we made a systems change, and now we're teaching you how to use this. So for a lot of the work that we do in quality improvement, it's how can we first, let's fix the system so that the system is nudging in a different direction, and then teach people about the systems change. Then you get the stickiness for it to fit to work. And we've done that over and over again in a lot of, when I worked mostly in quality improvement, try to achieve high value care, reduce waste in whatever it is, from lab tests, overuse of lab tests to Foley catheters to telemetry to, overnight vitals, whatever you name it. We've tried to use this framework, and it's been very, very successful because it really puts the power. It's the same even for gender equity, right? It's not like training a bunch of executives. The evidence on training is pretty weak. It's really about, is your culture supportive? Do you have that top-down visibility? Sometimes, I remember a project for, in GI using, IV proton pump inhibitor drips for GI bleeding, very expensive intervention, when in fact oral medications would be just as good. And the residents were like, well, I want to go into GI fellowship. And if that fellowship director does not buy into this, I'm not going to do it. And of course, the fellowship director is like, I want to do this. So we literally had him as the face of the project. So people, that's the culture. It was like, your attending who you want to impress wants you to do this, so that you can remove those weird barriers around inertia and change, so that people really feel like there's skin in the game. What's in it for me,
You talk about culture, though, and one of the things and I agree with you 100%. And, as I look at HSS and how powerful and how vital and important it is, and we see that, roughly 50% of the programs aren't doing it right now, there's part of me that wonders, boy, are there cultural issues there? Because it seems to me that's a pretty big barrier. And it seems to me that's a part that Chicago got right. It's Monday morning quarterbacking, but has Chicago always had a great culture, or how do you build that up so your team is ready to address some of those new big topics?
Well, I mean, in all honesty, I will say that, so what's interesting now about this paper is that we at the time knew we did not have the buy-in for full-scale curriculum renewal, right? So we knew that wasn't happening because, that takes a lot of buy-in. And we're about to celebrate 100 years in 2027 at the Pritzker School of Medicine. And we are a place of history and legacy, and, we evolve, but it takes time. And so we had a traditional 2+2, 2 years of basic science, 2 years of clinical. And it served us well for many years, but we needed to change. So we are now in the middle of curriculum renewal. We launched a new curriculum. So what's interesting about this paper was, how do you work with the system and the stakeholders that did not want full-scale curriculum renewal, and work with existing course directors to say, we're going to work with you so that we're not adding a new health system science course. We're not naming a health system science dean. We're going to go to the courses that you already teach and say, we're going to add in these experiences in health system science and label it as such. Now, what's interesting is that model, I believe, is helpful for the 50% that haven't hopped on yet. Because you have to ask, well, why haven't they hopped on? Maybe it's the cost of change is too high in their organization at that time because they're putting out fires, they have other things, or they're looking at these leading places that did get the $1 million and are like, I don't have the money to name a dean or, carve out the coursework. Now, you have to go with culture change. You have to build the momentum to culture change. So we do use a lot of change management techniques here. And so, I remember when we launched curriculum change, I talked about the Cotter's 8 steps, and we needed a vision. We were building a guiding coalition who was going to help us. But then there's pitfalls. So then when we convened for our curriculum retreat, there's this emotional baggage to the change. It's like a lot of our course directors, you don't want them to feel like everything is being ripped out from underneath them. So we wanted to stabilize, but also acknowledge that change is painful, So we used this 4-apartment model of change, which includes, the pit of despair, So it's like, don't get, we all might be in the pit, but we need to get into the sunroom, so that we will renew. And so I do think that, as a leader, how your what your capacity of your organization for change is. And sometimes, it's not going to be radical change. And so you have to figure out, well, how can you still innovate with the pace that you have and the places that you have? And that's why this paper was so important, because we worked with sort of the army of the willing, the course directors who were like, okay, I want to be a part of it. And that's how they are part of it.
I'd say it's so smart. And yeah, it's a way to be less disruptive when you're introducing HSS into the curriculum. Now I am curious. I think you kind of answered my next question there, which was, you've shared with us, okay, so this is why we did it this way, but there's some practical implications too, right? Just because of how big course loads are. So I'm curious, when you redo your curriculum, are you going to continue to thread the HSS content to this level, or are you breaking out more HSS specific courses? How are you handling that as you move forward?
Well, we've been successful with our current model, so we sort of wanted to focus on keeping what we had. So actually, when we started the full-scale curriculum renewal after this, after we'd implemented HSS, and in terms of challenges, towards the end of the grant, COVID hit, right? So, you're like, so literally it was like all of our simulations, we couldn't do anymore, right? And some despair over that, right? Having said that, we ended up flipping all of our, our students ended up having delayed clerkship starts, et cetera. But we ended up asking ourselves, how could our students contribute directly to the health system in this time of crisis? And because they were trained, they were the ones that came up with the ideas. In fact, I remember when I first started in this role, they were the ones that said, we need to open the free clinics. We have 6 student-run free clinics. We have enough PPE now. We can do it. I was like, okay, we're going to do it. And so I was super excited when they were, when we were recognized because of their hard work, sort of in those health system science innovations, because that is really the proof in the pudding, right? It's like, yeah, the survey showed that they felt great, but what did they actually do? And so it was almost, in some ways, COVID, as would never want this to happen again, but it provided this, horrible challenge that we had to meet, that our students, because they were prepared, had the experience that they could to actually support the health system and get recognized for it. So now into the new curriculum, what we also learned from COVID is that passive learning, my kids were remote, and, first grade remote is not much, and it's very difficult. And so there is this, even though there's so much digital in the workplace and in education, there's something about actually learning and going back to the roots of small groups, experiences and simulation and clinical encounters that really does matter. That's what really doctoring is. And so we knew that, of course, we want to keep all of this focused on foundational sciences, but instead of having like the most number of lecture hours, that we had, how can we convert our courses so that 30% of the course of every course has small groups, that we are including, that we're not using a deficit model of medical education. Like when I meet a medical student, it's like, well, I'm just an M1, I'm just an M2. And I'm like, you're a valued member of our team and our organization who helped us and can continue to help. And we can now give you credit for that. And actually, so now we have students that are working based on this grant. We have scaled up the opioid program, where we have students that are working alongside pharmacists to screen patients in the emergency department in their first year for opioid use disorder and dispense naloxone, life-saving drugs. And similarly, working alongside medical directors on the trauma surgery service and the hospital medicine service to identify patients who have high social needs and do more detailed social history, because you don't need a lot of medical knowledge to do this work. And so these are we call them the shine programs, ways for our medical students to really shine in the clinical environment. And so this is kind of what we've tried to do with the AMA experience with Vista, was sort of codify a lot of this into the new curriculum, and some of that take out of the courses even, and just have them as standalone experiences, if you will.
That is so smart, and I love the way of getting those M1s and then M2s involved with this from a very, very early age. Now, in the study, I noticed that there were certain things that you decided we're going to make this part of what this threaded curriculum looks like. And before I ask you about some of these specific ones, I do want to ask you about how because this is really interesting, I think, for anyone listening who's figuring out, okay, how can we really get a little bit more serious about HSS? So let's just talk about the selection. So some of the things that were in your first cohort were unit-based nursing, interprofessional team experience, patient safety simulation, choosing wisely, EHR smart phrase. And what I'm most interested in, my first question is, those are 3 very, very different topics. I'm curious how you chose them and how you prioritize them. Were you going for early wins? Were you going like, oh, we know a lot about this, biggest value? How did you make those selections?
HSS, like health system, when you say health system science, it means different things to different people. Like, if I'm talking to my CMIO, they're thinking about IT. And if I'm talking to my quality officer, they're thinking about quality. And for a medical student, especially an early medical student, not like they have their whole career ahead to decide if they're going to be the next CMIO or CQO or medical director or whatever. But for foundational, what do they need to know in these areas, And so we took a lot of the HSS competencies, and a lot of times the key is how to make the complex simple and digestible. And so it's kind of like the Khan Academy model, So for us, we wanted to think about ways to bundle things so that we could have gone really deep on cost of care. Okay. But then, then what about safety and team training? And we had done our survey, we had done a needs assessment, and we knew we needed to do better in a lot of these areas. So we wanted to do was bundle them and label it so people knew this was, whether it came in your American healthcare system course or your clinical skills course or someplace else in your internal medicine clerkship, people knew this was part of the VISTA. We wanted to brand that as such. And we picked areas that we knew each of them, going back, we wanted to have an experiential piece so that we didn't want it just to be a lecture, So in some ways, our earliest experiences with, before we had, went live with curriculum renewal, were in the VISTA program with doing these sort of experiences. And so that's why we focused on these specific areas, if you will.
Got it. I think that makes a lot of sense. This is going to be one of those questions that I ask that I'm going to be showing the audience that, unlike the two people on this program, I've never taken a medical course. I've never been a doctor, but I'm fascinated this conversation about patient safety. I can tell from your research, it's a big deal. As a consumer of healthcare, certainly I've been gotten prescriptions and I'm like, wow, that's a very expensive one. Certainly I've had poor communications with physicians. But patient safety is one that I know you talk a lot about, you write a lot about. Just provide some context here. Why is it such a big deal today?
So there's more cooks in our kitchen. It's like a very fragmented system. A Medicare senior might have over 10 physicians or providers, caring for them. One primary care practice is probably coordinating with 100 other, doctor practices. So it's not the days of Marcus Welby where it was like you had a family doc who, knew your whole family and, that one practice. And what I see from our patients is it's those transitions that things get lost, and so, most of my research is on communication around these areas, either team communication, handoff communication, doctor-patient communication. And so that's why, safety is really top of mind. Yeah, there's also two schools of thought. I mean, healthcare has not made itself safe. It didn't go through the aviation industry's journey of deliberate practice and, crew resource management until it has to with high profile medical error cases, So, and the measuring of it is also, sort of off to the, it's not, when a plane crashes, we see it, the pilot goes down with the plane, everyone wants to make sure it's improved. Although, here we are, there's the Boeing is in the news again. What's going on? A lot of that goes back to culture and what we talked about. So I think for us, our thought for patient safety was starting small. But what could a student do? And a few things that they can do are they can certainly speak up, empower them to speak up when they see things, even if it's just telling their resident, or reporting it out in their history and physical. And so the patient safety simulation we focused on was common healthcare safety issues that arise in a hospital, whether it's, the wrong name, wrong dose of medication, or a pressure ulcer, somebody who wasn't turned, or an inappropriate blood transfusion, or an inappropriate catheter. There's a lot of overuse in the environment too. And so what we did was we simulated what it would be like with a mannequin to walk into a room. And what we're really getting at is the idea that so much of safety is going on in the background. And so you need to actually boost situational awareness. So when you walk into a room, you're always on the alert for threat. And then you're able to speak up and do event reporting. And so that was the whole, we had people work in teams and kind of gamify it a little bit so that people felt that when they go into the clinical environment, they, a lot of students and residents, we've done this with residents. They're like, well, I didn't call that out because I assumed it was there for a reason. And I'm kind of the mindset, question everything, why is this happening, and because there's so much fragmentation that's maybe how you'll make the diagnosis or how you'll uncover that somebody actually needs care that they weren't getting. And so to me, that was an important piece, was that situational awareness. And then regarding the communication piece, especially with doctors and nurses, that's just like bread and butter, right? There's so much literature that shows if doctors and nurses are on the same page and have better communication, the patients do better. Like their outcomes are better, mortality in the ICU. But it's so bread and butter, but we focus so much time training students and residents on speaking to other doctors or speaking to patients, but we kind of leave the nurse off, And so that was our focus, was what do nurses do? How do they communicate so that they are your ally? I mean, it's, going to be July 1st. Our interns have already started, and now everyone talks about how your first rotation is made or broken by how helpful the nurses will be to you. And so it's to your advantage to work with them and be team players so that you take all of that information into account.
That is one of the biggest lessons that a senior resident or faculty, making sure that you build that relationship with the nurses so that they got your back. But while I was listening to you, the simulated patient safety, there's a secondary benefit which I'm sure you're aware of, is if you've never been in that environment, if you never walked into a patient's room or a clinic as a student, first time you do that or the second time you do that, you're processing all that information, and you're thinking about it, why is the bed there? Why is that thing beeping? But giving them that exposure, even if they're not mastering all the patient safety components, when they actually go into a patient's room, they're not processing it for the first time. And that situational awareness, it allows them to get started at a higher level than if they were doing it because I remember as a third year student going in, it's like, holy crap, there's a lot of information here. How do I process this and what do I need to process?
Yeah, exactly. And so for our new curriculum, we now have, we actually originated the white coat ceremony, one of the first schools to do the white coat ceremony, but it used to be that you put your white coat away for 2 years, or like until you go see a patient, maybe with your resident to do a history, like in your second year or something. And now what we do is with our standardized patient program, we train our first year students in week 1 to work with standardized patients. And partly we did that because it's like, look, they're working in free clinics. They're in medical school now, right? So they can do more than shadow, right? And we want to empower them to be part of the team so that they can contribute. And so we actually have gotten great feedback that they would like more practice and more skills practice in that area. So that's just an example of how again, that experience fueled our desire for even earlier exposure to our standardized patients and simulation in the clinical setting.
One question that I do have for you is when you talked right now, you're revising curriculum, right? But what's interesting to me is so many of these topics, so many of these HSS topics, they feel like they just have to be more dynamic and updated on a regular basis. And let's face it, when we talk about curriculum is one of those things that isn't known for changing constantly, changing rapidly. I'm just curious, when you look at layering in HSS content, is it more challenging given the dynamic nature? Do you feel like you need to revisit it more often, or how are you thinking about that? Because it sounds like you're going through that right now, right? You're developing this new curriculum, and it feels to me like these topics are so relevant that they're not necessarily as evergreen. So how do you keep up to date with it?
Well, I do think there's a little bit of refresh. And so actually I'll take a story from the GME, our GME time. We just welcomed our new residents and we have a simulate. So thinking about skills practice, we we know that graduating fourth year students often are not coming straight from the wards or clinic. They often do some vacation, well deserved, and maybe some, lighter rotations towards the end, maybe finish research. And so it could be, I remember being an intern being very nervous because I hadn't seen a patient in a while.
Right.
So what we do is we again use simulation, and we do a telesimulation. So we actually do some simulation with procedures for, the surgeons and, ACLS, but we also do a simulation like practicing your communication skills. And this time it's more advanced communication. It's calling a consult and doing a handoff, which is like the bread and butter of what you're doing as an intern. And we have mock cases that we've created. And then we, when they sign in to the Zoom, they might get me as their co-resident that they're going to call first play the fellow, calling the consult. They're calling a consult on. And then I switch to, they're going to hand off their patients to me. And they're handing off more than one. And they watch some modules on how to practice doing that. And I just saw the evaluations. They appreciate the faculty feedback and the opportunity for skills practice because it lowers their anxiety level because they're like, okay, I can do this. I'm getting back into the swing of things. And what's interesting is some of our faculty facilitators are actually health system leaders, and so this year they're like, oh, the Epic thing changed. So can you put a plug in to say that the new smart phrase is in Epic for the handoff. And next year I noticed we need to change it because the consult page is a little bit different. So now you can imagine, every year is different. Like, we did this through COVID, right? So then we took one of our patients and we were like, well, these set of patients would come in. So the one with respiratory distress, we said they had COVID. And then the next we said they were COVID negative because it would be weird to be passing off a patient in respiratory distress and not say they were COVID negative. So every year, and I think that that's important because that's like true for any medical knowledge, right? It's like cardiology trials change, right? And there was a famous dean, Lee Goldman. I think he retired, but he said, half of what I learned in medical school, I forgot. The other half is wrong. The problem is I don't know which is which. So we are going to be lifelong learners. And, I'm thinking about AI now. We're doing a lot around, what should we be teaching about that area? And so in some ways, our goal is to empower students and residents to be lifelong learners and empower them with the frameworks to learn because some content doesn't change, but some will, and they need to be ready to adapt to the change, I
think what you brought up there is really interesting, and I'd love to ask you about that AI, because there's two ways that I see medical education approaching AI. One is training students and residents on what AI is and how do you understand it. The second component of it is how do you leverage AI to teach differently.
Yes, yeah.
So, for example, you brought up the facilitated conversations that the faculty are having with students, and that is hard to scale when you have a lot of students.
Yeah, so I think the focus on AI right now, it is the new hot thing, but I think we need to be careful to not, a lot of people are like, how, are you going to do AI in year one? And I'm like, no, you still have to learn how to do a physical exam, and so maybe, we have a research requirement here. So we have some students that are learning AI through that way. And medical practice will change. It has changed, right? And what we need to do is recall that we are constrained by the present to train doctors of the future. So how can I train doctors of the future with the systems of the present? Because even if we look at where the innovation is happening, I do not think the AI is happening, the innovation is happening at the big academic houses, right? Right now, a lot of it's happening like, in these startups, corporate, world. That's where I see a lot of the innovation. So I think my job is, again, empower our students to be able to receive that information and make decisions about how to use this technology, whatever it is, at the time that they receive it. And so we're working on a new course, a simulation-based course right now called The Future of Medical Practice. So after you finish your clinical training and you decide what you're going to go into, where you're going to go into the Sim Center and you're going to learn about AI and digital health and 3D printing and nanomedicine and, all this other stuff that you would count as things that you might not have seen in the clinical setting or seen a little bit. And then you're going to practice. You're going to actually see how it's used. Robotics, what are the use cases? And then how do you apply them to the specialty you're going into? And then what are the ethical challenges? Because the doctors we train, they're going to be the ones that decide how to use AI and how will it work with them. There's no stone tablet that I'm going to give them. I can only give them the method to think about it. And so that's what we're thinking about right now. And then back to your other question about I do think AI has a lot of potential to reduce the burn on medical education and clinical care. We already see there's a lot of notes that we write and a lot of, pajama time. Like, could AI help with that? I mean, I would love an AI assistant to help me, manage being a working mom, so I look forward to the revolution. And similarly, I think a lot of our medical educators, can leverage AI to help with a lot of the stuff that they need to do, goals and objectives, assessments, et cetera, all the way to could we scale some of these simulations better with virtual reality? I mean, I think that's really where we need to be going.
Wow. That is so well said. I think my last question for you, Vinny, is when you did this paper, the results were the M4s. Guess what? They knew a lot more about HSS because of this curriculum being multi-threaded into there. I'm curious for somebody like yourself, though, was this, were you surprised by how strong those results were? Or was it at a certain level common sense? Like, if we expose the brightest minds in America to this, they're going to do really well. So I'm just curious what your thoughts were when you looked at those surveys.
Well, I was pleased, I was pleased that, they got it. And I think it does speak to the idea of, so I know deep learning has a definition in AI. Even before AI ever existed, there was this concept of deep learning with repeated, again, it's repetition, right? It goes back to expertise and the 10,000 hours to become like an athlete or to become a musician, right? And so this one and done 1 hour lecture is not going to do the trick, right? So it really is about creating an environment where people want to pull the information. They want to learn it. Then giving them an opportunity to practice, and then giving an opportunity to apply. And so that's the part I think that's really exciting in medical education is, can you graduate students, or like when even actually go to residency, where they've not just learned it, but now they've actually developed new programs, made it better, because they're going to be the leaders of the future. So that's really what we try to do here, is empower them to make the change so that we are creating change agents for the new healthcare system.
Very, very well said.
Not going to be enough for us to, again, it goes back to we can't assume that passive learning will result in the change we need for American healthcare.
Excellent. Vinny, thank you so much for joining us today. This has been a lot of fun.
Thank you. It's great to chat with you, and look forward to learning more.
Wonderful. I'm going to take it out of here, folks. When we look at how to fix healthcare, there are no easy answers, but for sure, one of the solutions is going to come from how we train tomorrow's healthcare leaders, given the frameworks that we have today, which is a great line that Vinny gave us. Here at the University of Chicago Medicine, Pritzker School of Medicine is one of those programs leading the charge. And out of the gate, the results are obvious. Medical students being trained about the context of what's going on in healthcare, guess what? They're better able to respond. I'm reminded about the joke of two fish swimming in the water. The one says the water feels cold today. The other says, what's water? Simply put, HSS is the water that these talented professionals need to navigate so that they can serve us to their best abilities. We've been joined today by Vineet Arora, a Herbert T. Abelson Professor of Medicine and Dean for Medical Education at the University of Chicago Medicine, Pritzker School of Medicine. Feel free to become one of more than 50,000 followers of her work on LinkedIn, or check out her Wikipedia page. First guest we've had on MedEdge that has her own Wikipedia page. You've been listening to MedEdge. MedEdge is brought to you by our good friends at Medtrics. Medtrics, practice medicine, not software. Learn more about them at medtricslab.com. For my co-host Santosh Cherry and CEO of Medtrics, and everyone else on the MedEdge team, I'm Marcus Grimm.